that we are unable to correct it through the other modalities.
Thank you again. One comment about this biometry. Really, ESRS website, they have very good IOL calculator, okay? And really, I encourage everyone to use it.
Yeah.
So when you put all the information, you can choose toric, you can choose both LASIK, you can choose also keratoconus. So,
Yeah.
so I teach the nurses to use that website to do the calculation for these cases. So it's really help a lot to avoid any error and better formula and free of line. So, so basically, as we discussed earlier, just about keratoconus. Yeah, please. Keratoconus nowadays is good that we had many modalities to treat, all to make the patient happy with the vision and without the risk of any problem with the cornea graft. So as we say earlier, we try to avoid cornea graft as much as possible, not because we don't like to do it, but just for the patient benefit long term. Can I have the pointer, please? So phakic implant, this is one of option modality. Basically, the phakic IOL is one advantage is the corneal sparing. So with, as you know, keratoconus is a weaker cornea, so we prefer not to touch the cornea. It's very high optic quality, it's reversible, it has wide range of correction at myopic and hyperopic, and the sole goal for toric implant itself is just to correct the myopia and the stigmatism. It doesn't correct the high order aberration, and to provide the quality vision similar to the spectacle. That's very important message, that we aim it to give it the same vision as the glasses. The most common using posterior chamber phakic implant, all of us familiar, most of us use ICL, would have a good range up to -18 with 6 diopter. IBCL, which is Indian version, really they have even wider range of correction. Biotech also have a good range. Iris Glow is a good option, by the way. We tend to avoid using it much now, but really maybe for keratoconus is good for two things, by the way. There's no problem with the angle, and there's no risk of rotation, okay? So, but we don't use it much, but that's the different. Regarding the preoperative assessment, when you had keratoconus, think about phakic implant, really the refraction, the most important one. You have to have very good refraction, cycloplegic refraction, and the patient should be happy with the vision with the glasses. The second thing is you're looking for corneal tomography, looking for vertical coma, because vertical coma, that's associated with the quality of vision. If vertical coma more than 0.5, usually associated not good quality of vision. Also looking to high order aberration, the total. Ideal should be less than 0.6. Anyone had more than one, that really may be considered as poor candidate for phakic implant. But any phakic implant, you need to look at endothelium, count it should be good. And remember that previous keratoplasty, it doesn't prevent people to have phakic implant as a treatment option. It should be stable keratoconus, or when you do cross-linking, you have to wait for at least 1 year. Better for people who had contact lens intolerance. Remember, contact lens is the best vision keratoconus can have. So if someone happy with contact lens, leave him alone with contact lens. Don't to try to encourage him to do more surgery with unnecessary. It's very ideal for people who had anisometropia with the glass because they don't have an option. So it's very good to correct it with anisometropia. You should have consistent astigmatism and adequate anterior chamber depth, which contraindication for the phakic implant. If someone progressive keratoconus, need to stabilize it first. If someone had poor quality vision because of regular astigmatism or because cornea scar, that's not good candidate. Endothelium compromise, or someone had shallow EC less than 2.8 for ICL. What is the problem with the keratoconus different from the normal patient is really the size of what we take for normally. The anterior segment for keratoconus is slightly abnormal because it's stretching, so you may have a not accurate. So the ideal one, you need to use UBM to look for sulcus to sulcus. It's really important if you had access to that. Majority of us, we don't have, so we could use anterior segment OCT, look into the angle to angle. White to white measure, which usually standard we use for phakic implant, it tends to be variable and take it with caution. So it really could be overestimating the size. Remember, if it's low vault, it's cataract, but usually we tend to have higher vault, and that will cause narrow pressure and the iris shivering and pigment dispersion. So keratoconus in general need to very more precise about the sizing. It's very crucial for keratoconus more than the normal one. The second thing is AC depth. AC depth in keratoconus, because the cornea is bulged, first of all, the AC depth measurement is not accurate. With different machines, different areas, so AC depth is not accurate. what like a normal person, but also it tends to be slightly deeper. So for that, we may choose a larger ICL, and that will cause more volt. And that's, so always remember to use, better to use multi-devices, anti-astigmaticity, Schoenflug, UBM, and together to have the average and more consistent parameter. Toric ICL is a good option for keratoconus to consider, but it should be regular astigmatism. Remember that you should be consistent with axis with the different topography. The glasses should be all consistent. You expected still some regular astigmatism. Avoid overcorrection, but also very important to have alignment and also avoid the rotation. Complication is it could be the vision not as good as patient. Sometimes patient put in their mind he expected the same like contact lens. It's not. It's always remember, always put it to the patient. Our aim to give you the same vision as the glasses. It could be better, by the way, but don't promise more than that. You could have residual refractive error, volt issue, rotation is low, is about less than 5%, and you could have a cataract like with any phakic implant. For residual refractive error, you could consider glasses. Remember, once you put, if you put toric ICL inside, same thing with toric implant for cataract, the patient cannot wear hard contact lens anymore because you cannot do that. So that's very important to keep in mind this one. You could consider IOL exchange, or you could do topo-guided refining with the cross-linking. Ideally, if someone had a regular cornea, better to do like intercorneal ring before, improve the shape, then do the phakic implant. Yeah. This is a systemic review meta-analysis for the effectiveness of posterior chamber IOL. Look into different study, a 16 study, and look for, they have treatment for mild to moderate keratoconus with phakic implant. The majority of patients have a stable refraction before going, and many of them they have corneal cross-linking. And uncorrected visual acuity improve at 2 to 4 Snell chart. Best corrected visual acuity improve in majority of people more than 90%. And the refractive accuracy is very accurate. It's very predictable, almost 90% within 1 diopter of the refraction what we target. They still have predictability good despite of some regular cornea, as we say. Cataract can be a problem with any phakic implant, as we know. And there is another study, Kimia and Shimizi, is also looking to the stability and effectiveness and safety, both are proven that's very effective and safe procedure for keratoconus patient. So ICL is a valuable, safe, predictable, effective option for stable keratoconus or after corneal cross-linking, recommended for a patient who has contact lens intolerance or people had an isometropia, they appreciate it more. It's a complementary to the other procedure, intercorneal rings or BRK. Careful base selection is the key. A patient should be reasonable with the glasses vision, good refraction measurement, and stable. Sizing is very crucial to keep in our mind. Always use multiple devices. Look into better to have the sulcus, or at least angle to angle. Careful with white to white. And really the AC depth and white to white can be variable, but if you take all the measurement and caution, you should have a very happy patient and good result. And thank you very much.